plans. So a couple of key points and highlights from the report from me, Carl. Happy to open up for any questions and further discussion. Thank you.
Really helpful, Peter, and very accessible as well in terms of the report and the way you presented it. So big thank you for that. So again, we have 2 or 3 colleagues that want to respond to the report. We'll take 2 or 3 contributions, Pete, and then come back to you if that's okay. So we'll go to Steve, Mick, and Robert in that order.
Thanks, Pete. A really helpful report as always, and congratulations to yourself and the team for setting things out clearly. You have actually just covered probably some of the points I was going to make, but I will make them still. Firstly, I think it's important to acknowledge how significant the levels of savings deliveries is this year. I mean, it's I think about double last year, and that's an extension on previous years. And I appreciate that, that's only the result of the actions across the whole community, the whole organisation, and that, staff day in, day out are having to make quite difficult decisions to deliver those savings. So I think it is important we acknowledge that as a board. I was going to ask, but you did sort of cover it, but perhaps you could just reiterate. Obviously, we are 2.9 million adrift at this point, so extrapolated that would come to about 5 to 6 million at the year end, above our 28.3 million deficit. So just looking for assurance of that actions are being taken, or to identify mitigating actions, obviously taking account of also any emergent findings that Hayley mentioned earlier. And then finally, again, you did refer to this, but just to seek assurance on the delivery of the capital programme for this year, because it's slightly off profile at month 7. Thank you.
Mick.
Thanks, Chair. I was going to make the same comment that you and Steve made about, the quality of Pete's presentation and the quality of the report. We may not like the financial position we're in, but I don't think anybody could say that we don't understand why or what's driving that. And the clarity of the report is a great credit to you, Pete, and your team. But my question was about tariff. Sorry, I've lost my question. Tariff inflation. It might be my naivety, but I thought we had an annual sort of kind of commissioning framework, and we went into agreements with providers to provide us with the service. But I don't quite understand where tariff inflation comes from. And I just wonder, do we have levers to control that? And if we don't, does that leave us vulnerable then to further escalations in tariffs if are those things outside our control?
Thank you. So we've got another couple of contributions, Pete. So we'll come back to you now, so that we can we can deal with things in digestible chunks. Please.
Yeah, I appreciate that, Carl, because I was scribbling away furiously. I'm trying to keep up with the questions. So just to pick up on Steve's points, yes, you're absolutely right, Steve. It is a significantly higher target than the Health Board has set in previous years. That is 6.3% of our total funding. So it is a significant target. Pleasing to note the progress. It has required a lot of effort, focus, and attention from the whole organisation. And we need that to continue. We need to go further, and we know that's an ongoing challenge. In terms of the 2 million adrift, yes. So we have a risk to our deficit plan of circa 6 million. That's in the areas I described of the additional tariff increase, circa 4 million, the JCC circa 1 million, and the employers' NIC contribution difference between actual and funding of circa 1 million. Given where we are, given the forecast to the end of the year, that is forecasting to identify an operational underspend, which currently would offset our savings shortfall and contribute circa 1 million towards those additional pressures, giving us a balance of a risk of circa 5 million. I think that focuses on the areas where we have seen improvement around variable pay and around our mental health provider, as referenced in the latest month, and there is some further action in the commissioning space around ongoing negotiations and discussions. So We are tracking those and assessing those, and we'll be calling that against our position as soon as possible to understand what that means in terms of further ask. In terms of month 7 capital, yes, it is the profile of spend against what we're expecting where we are is that we're not anticipating any significant problems. We will remain within our capital resource limit, and we're not expecting any significant slippage against those plans. We are always in a position where if any other additional capital slippage becomes available nationally, we look to maximise any benefit or any additional funding from that as well. So hopefully that gives a bit of confidence in that position. And then in terms of mixed questions, so every year in NHSE there's a cost uplift factor, the CUF as it's referred to, and year on year this is something that we're funded for. If there's any difference between our allocated uplift and the CUF impact, that is additional funding that we normally receive from Welsh Government. In terms of this year's tariff increase for those unscheduled care pathways, this was a decision made by NHSE to recognise within the English system additional costs of providing those services. So it's a bit of a one-off situation which has resulted in additional costs for us. I will say that we continue to work through and understand the exact impact of those costs in terms of the activity to date and other factors. So in our position, it's based on actual activity to date plus a forecast to the end of the year. So there is potential for some movement of that, but it is something that we need to be cited on, we need to be aware of, and any future decisions in this sort of area would result in additional ask for us. So it's ensuring that we're very clear on the level of activity that required in those areas, or the actions we can take to minimise those as far as possible while providing the appropriate care for our population. I think those are the points to cover, Carl.
Thank you. Just want to give Steve and Mick an opportunity to come back if there's anything that you want further assurance around.
I think the response is fine. I mean, obviously, we will continue to monitor any progress towards identifying further mitigating actions to bring us back down towards the 28.3 million. I think.
Thanks, Mick, for the explanation. Maybe something I need to understand more about, but it does seem, bizarre that we have a planning process where we've set our budget and then, we're subject to, outside influences that take us off track. But I'll find out more behind the scenes. Thanks, Mick.
Thank you.
Thank you both. So we turn to Robert. Well, yes, to Robert and to Ronnie.
Yeah, thanks, Peter. I'm not sure whether we need to call in a colleague to answer some of this. I don't know. But on the community hospital delays, what I couldn't see from that slide, really, I may have missed it. I couldn't really see how things have changed. In the last 6 months, a huge amount of work has gone on behind the scenes with the council and other activities as well. And I was sort of hoping that maybe some of that would have worked through. Is there any evidence of that in the financial indicators? And do you think, and perhaps colleagues think, that those efforts and those improvements will show themselves within the financial year? Thank you.
And let's bring Ronnie in as well, please.
Thank you. Some of my questions have already been asked, but perhaps I might just raise one additional one, please, Pete, and that's on page 4 of your report. And it is a very clear report, as others have referenced. There is a statistic that our forecasted agency and locum spend was an average 5.5 of total forecasted pay against the Wales average of 1.8. So we are a factor of 3 over the average. And I know that there's been an active savings programme. I understand the real efforts that have been made around this, but I'd just like to be assured that there is still active focus on this as an issue, and we are making additional savings where we can. Thank you.
Pete?
Yeah, thank you. So thank you, Robert. So yes, what I can say, and Elaine may want to come in and add to this, is that we have seen an improvement in terms of the action taken around our delayed transfers of care. I think your comment is well made, and what I will do is look to include a reference to the previous year's costs in the report. But that figure has come down. What I will do is I will add a follow-up comment on that just to clarify exactly what those previous year's numbers were, and we'll build it into the report going forward. I just pause there in case Elaine wanted to add anything around the work with that we're completing and with our local authority colleagues around those delayed transfers of care.
Yeah, thanks, Pete. I think there's a couple of elements in terms of community hospitals and delays. I think that we made significant improvements last year, and our key focus in terms of cost reduction this year was to try and reduce the number of community hospital beds that we were using in England. So we have reduced that this year. We've currently seen about a 40% reduction in the cost of those NHS England community hospital beds by repatriating people sooner into Powys. So that will take up some of our own Powys beds, but we're also doing that now through some of our community-based services. We're continuing to work with local authority colleagues, particularly around the delayed transfers of care. So we know that one of the most significant areas for us historically was assessment delays for the local authority. We've seen those assessment delays within the last couple of months come down significantly. So we are seeing some change there. That work to retain focus on our pathway of care delays and to seek to make improvements isn't going to end until we've managed to end it. So I think that work will continue for a good time going forward, because we know there remain challenges with the market, and we know there remain challenges with enabling people to come home. I was just going to comment, Pete, very briefly on the agency reduction as well, if that's okay. And I know that Kate and Deb might want to come in also. So you've noted that in month 7, we've seen a slight uptick in terms of cost. That relates to medical staffing, and that specifically in month 7 relates to medical care in Brecon for us. So that's physical health ward, and that's a short period of time until January to cover a particular gap that we've got in terms of medics for the ward there. But there remains an ongoing focus in terms of the escalation approach that we've implemented to support the reduction in agency. And we've also seen this month, for the first time, for example, 2 of our mental health wards not needing agency and expecting not to usually need agency going forward. So that's a big step forward for us as well. So that work will continue also.
Thank you. So, Pete, should we bring in Kate and Deb, or?
Yeah. Yes, please do, Carl. Thank you.
So please come in. Kate and then Deb.
Yeah, so thank you. Just briefly, in terms of the medical locum spend, then Elaine has spoken about Brecon, which is a temporary issue, and we're confident will cease to be an issue after Christmas. And I think the challenge we have is that our biggest medical workforce is in mental health, and we know that nationally the number of vacancies in mental health is more than double that of any other specialty, which is very significant. So that is an issue. In spite of that, I just wanted to give you some assurance that Ben, our CD in mental health, is, well, the whole team, but they're very proactive in terms of recruitment. It is a almost full-time process, but we are going through another round of recruitment, which we're very optimistic about. We're recruiting against the tide and continue to do so. We do have some staff turnover. We've had 4 overseas doctors onboarded who are all doing extremely well. So in spite of the challenges, there is grip, and we are anticipating, I don't think we're ever going to get that spend down to 0 if we're realistic in the current climate, but it's a continuous effort, and I think we're optimistic that that spend will come down yet more over the next small number of months.
Just to just to add to Kate's point and just continue in the mental health theme, we've got 4 overseas nurses arriving in January into mental health as well, so that's positive. We do have another tranche of healthcare support workers as well arriving or onboarding, some of whom will go into mental health. I guess just to broaden it out from ward areas, we're also really focusing in now on off-ward agency spend and working with 4 of the highest cost areas, and therefore looking to revise maybe any working arrangements or to do some targeted recruitment. So a significant amount of work still ongoing, Ronnie. We did a very, very focused piece of work, number of execs involved on wards. Now we're extending that to other hotspot areas and off-ward agency.
Thank you. And back to you, Pete. Any additional responses or comments from you?
Just to add, clearly an area of significant focus and action. We have seen improvement, but Ronnie is exactly right. We're still an outlier in terms of our percentage. We know that there are some factors within that relate to us in Powys, but as others have described, it's a focus area when we're looking to improve further. Obviously, number one in terms of the patient care, continuity of care, and all that comes with that, and then secondly, the financial impact of those use of agency and other type staff. Thank you.
Thank you. Hayley wants to come in and add an additional point, and then Robert, Ronnie, if you want any further assurance, then please do indicate that. But let me invite Hayley to comment.
Thank you. It was just one additional point I wanted to raise around some of the issues around the mitigating actions that we need to take. One area that Pete highlighted was the full year issue around our joint commissioning committee spend being £1 million pressure for us. So just wanted the board members to be aware, in the joint commissioning committee yesterday, we made clear that further additional mitigating actions would need to be explored to reduce that pressure on every health board, but in particular for us and Betsy, it's a major issue, so that that work will be done and will be coming back in the JCC space as well. So clearly we've got to do our own work as a health board as well, but I just wanted to reassure you with regard to that £1 million cost pressure, there was agreement for additional actions to be transacted and moved into recommendations for approval by the JCC yesterday.
Thank you, Hayley. Anything else, Robert, Ronnie? No? Okay,
No,
thank you. And thank you, Pete. So we received this report for assurance, and the recommendation is that we receive the financial report, we take assurance that the organisation has effective financial monitoring and reporting mechanisms in place, and also that we consider and discuss the financial forecast for 25-26 of 28.3 million, and our underlying deficit of £42.1 million. Again, please indicate if you want to comment on the recommendation or indicate if you don't support it. That too is supported unanimously. Thank you. And we have a bit of time. We're due a lunch break around about 1 o'clock, but I'm going to suggest that we go to item 3.5 on our agenda, the IQPR, the Integrated Quality and Performance Report. Nick, I wonder if you would be happy to present the report to us, then we'll have our lunch break, and then we'll come back after lunch for the discussion and the response to the report. So over to you, Nick. Thank you.
Thank you. So in terms of introducing the report, I'll pick out the main points. So as a provider, we're maintaining good performance on 104 and 52-week planned care targets. Our diagnostics position remains a cause of concern, with the echocardiogram position improving, but still some difficulties with non-obstetric ultrasound. However, there is a recovery plan in place to meet the 8-week target by the end of March across our diagnostics provision. The report notes that in terms of demand management, our MSK referral optimisation service started on the 24th of September, and we will be monitoring the progress of that through our planned care board on a quarterly basis. In terms of therapies waiting times, due to the small nature of some of our services, they remain fragile, and that has caused some issues as reported in this month up until September, but again planned to recover by December. We continue to meet all of the mental health measures for children and young people, and there is improvement noted in the report on adult mental health measures, particularly with regard to psychological therapies. We are reporting improvement on the waiting times against the target that the board agreed of 104 weeks in the context of our annual plan for 25-26. Obviously, we had that blip in referrals over the summer, and the service have worked hard to manage that. As you can see, reporting that we will be back to no patients waiting over 104 weeks in that service by the end of October. And it is worth noting that although the board that we as a board agreed to maintain that 104-week target, the Cabinet Secretary's expectations is to eradicate all 3-year waits across Wales. So we are ahead of that. Our minor injuries units continue to perform well against the relevant standards, and we've discussed the temporary service changes earlier that we made in those services earlier in the meeting. Turning to commissioned services, pleased to see that Swansea Bay and Howell are meeting the planned care targets for our patients, but variable performance is still evident across the rest of our NHS Wales providers. The cohort of long waiting patients in Robert Jones and Agnes Hunt is still evident, and as you know, through our LTA discussions, that is likely to continue, with projected to be around 60 patients by the end of March. We have written to NHS Performance and Improvement around that cohort patients to see if there's any support for us for backlog removal, and awaiting a response. We are, however, working with that team and the spinal surgery lead for Wales on clinical validation of that waiting list, particularly around the long waiting outpatient patients, to see if there are any alternatives to treatment for patients on that spinal list. However, the advice of the clinical lead for Wales is that that won't affect those very long waiters at the end of the list, hence why we've written to NHS Performance and Improvement. As noted in the report, this report for our provider services is for the September period for NHS England, due to the data flows from our contracted providers and the requirement for validation of the information that comes to us for our NHSE providers. The report shows the August position, and in Wye Valley and Robert Jones and Agnes Hunt, we're seeing those first signs of lengthening waiting times, as we'd expect, given our commissioning intentions took place for treatments in those providers from the 1st of July. We continue to monitor the impact of that change monthly via the Executive Committee, and we'll continue to report on that through this report for the rest of this year. And as you can see, we monitor the quality impacts as well as the access implications. And at the time of writing this report, we'd had 46 concerns about that change that we made in our commissioning intentions. As of today, that's 50 concerns. So we are now experiencing around 2 a week of concerns around that change. And the majority of those are general concerns about the change to our commission intentions, with a much smaller number being individuals raising concerns about their own care. And we deal with those with compassion and within our normal processes on a case-by-case basis. We also track, ask the providers to report any additional harm or causes for concern that they are picking up through our CQPRMs, and we haven't had any causes of concern around that reported to us to date. Equally, we've had no serious reportable incidents around this either. Katie asked a question around whether it impacts in other parts of the system around this change that we're picking up. And I've checked with colleagues, and there isn't anything we can see through our therapies referrals. And Elaine has said that there isn't anything that's been reported of significance through conversations with GPs or the LMC, but Elaine may want to comment on that further once I've finished speaking, or after lunch, when you'd prefer that to be the case, Chair. We continue to experience variability for our residents in our commission services for cancer and urgent and emergency care. And you can see that again, as Katie picked up concerns about ambulance waiting times, that we continue to monitor that and advocate for our population through the JCC mechanisms, bearing in mind that ambulances are commissioned on a national basis through the JCC. But you can see, particularly with regard to the new target of the purple category, that there is cause for concern around our population, and we raise that through the JCC mechanisms. On a specific point around patients being advised to travel themselves to hospital or taking it or doing that themselves, Katie, I think my own understanding is that is part of the advice that can be given through ringing 999 or 111. But we will check exactly what guidance there is for that advice to be given to patients, whilst understanding that the Welsh Ambulance Services Trust will try to get ambulances and their skilled clinical paramedic crews to those patients who most need them. I think that's it from me, Chair, in terms of introducing the report. Thank you.
Thanks very much, Nicola. Elaine, would you like to come in on the GMS provision?
Thank you, Carl. Yes, just to reiterate what Nicola said, in my conversations with general practice colleagues, what hasn't come through from there is concerns specifically raised to me around our commissioning choices and decision. I think that there's a wider issue that is raised in general practice around the impact on their services and access to their services for people with longer waiting times. And I didn't want us to not recognise that actually if somebody has a 1 year or 2 year waiting time, there is a strong likelihood that they will repeatedly need to go back to their general practice for further support, further medication, and potentially further symptom control. And that does have an impact on our GP practices. Thank you.
Thank you both very much. So if there are no other presentational comments, then thank you, Nicola. We will then go to our lunch break, and we have a scheduled half-an-hour lunch break, in which case we will reconvene after lunch at 1:30. So look forward to seeing you then, and bon appétit. Wel, croeso nôl i'n cyfarfod, a dyma ni wedi mwynhau egwyl cinio ac yn ailgydio yn ein hagenda ar gyfer ein busnes heddiw. So it's good to see you. A very warm welcome back after our lunch break. And also a welcome to Jennifer Owen-Adams, one of our independent member colleagues, who wasn't able to be with us this morning, but has joined us for the afternoon session of our meeting today. So good to see you, Jen. So before we broke for lunch, Nicola Johnson presented to us the Integrated Quality and Performance Report, item 3.5 on our agenda. And so that report now is open for discussion and for response. And I'm going to invite Robert to begin the discussion. Thank you, Robert.
Thank you. My question is about the notes you've made on Wye Valley Trust. And you note that this is still the best performing provider, even though the throttling back of commissioning has begun. In the past, we have used waiting times as a means of comparing providers, producing a hierarchy in which, as it usually turned out, South and Wye Valley were amongst the best providers, particularly over the long waits. Am I right in presuming that this will no longer be possible with Wye Valley because, of course, it's Powys Health Board that's partly influencing things? Presumably Wye Valley's performance will eventually be what the Welsh target is, as question one. And secondly, and this is a type of impact assessment, and perhaps things have changed, I don't know, since we last revisited these. Could you remind me what modelling suggests will be the impact of the throttling back on the overall waiting times and progress against Wales's ministerial targets for Powys patients, if and when both South and Wye Valley conform to our new commissioning arrangements? Thank you.
Do you want to pick that up immediately, Nicola, before we go on to other contributions?
Yes, thank you. So the decision that the board made in March, as you quite rightly say, was to commission to Welsh waiting times, and the logical conclusion of that and the work we've done with the providers is that it was very important in terms of equity for the whole of the Powys population. And the logical progress of that is that waiting time should equal out across all the providers at around the level of the Welsh targets. So I take your point on maybe the way that the report is written. There is no intention to have like a league table of providers against the access times. And what we will do going forward is, if it's not quite coming over like that, is we will objectively report against those waiting times and where the providers are. So we don't have a league table. There's no intention for us to have a league table like that. So in terms of progress, the difference between the Welsh waiting times for treatment and the English waiting times this year is around 9 months, or is around 9 months by the end of the year. So we can see that over the next year or so, those should equalise. We do need to note that Shrewsbury and Telford Hospitals NHS Trust, as noted in the report, hasn't implemented the commission intentions. And as we've noted in other reports, we are in dispute with them about that, and that dispute has been referred to Welsh Government.
Thank you, Nicola. Robert, would you like to come back, or are you content?
So just to clarify then, Nick, have we modelled the effect then on the ministerial targets?
Apologies, Robert. So we've modelled with the providers the impact of them booking to Welsh waiting times in terms of the amount of activity we would need to commission from them and the financial.
And those are
impact.
the ministerial targets. Are they those are the targets?
Yes, so
Yeah,
104
okay.
weeks and 52 weeks. Yes, apologies.
Right. Thank you, Chair.
Thank you. And so we go to Steve and then to Mick.
Yeah, thanks, Nick. Good paper as always. A couple of questions from me. Firstly, you reference in your paper challenges with in-reach capacity fragility, which I know has been an ongoing concern, but I just wondered if there's any evidence that our change commissioning intentions with our English providers who also provide in-reach services is having an impact on in-reach services. I know it's early days, but just something that we will need to keep on in view. And in terms of ambulance response times, what assurances have we had from the JCC that they are engaging with Welsh Ambulance Services Trust to improve waiting times or response times for Powys residents? Thank you.
Nicola.
Thank you, Steve. In-reach fragility is not new to us, but I take your point about the change, and are we seeing any impact of that? There's some anecdotal stories, literally, of some difficulties, but you'll know that we did a deep dive report. Elaine's team did that with support from my team to the Finance and Performance Committee, and we're due to do another one of those in Q4. So we will be able to get more evidence from a quantitative point of view, sorry, then whether the change has made a significant difference, and that, you know, we look forward to seeing that report when it's brought forward. In terms of ambulance waiting times, it is early days. We do attend the ambulance monitoring meetings through JCC, and we pick that up in the context of their performance reports. Hayley may be able to pick up if there was anything through JCC specifically for Powys yesterday, but obviously we continue to advocate for our patients and through the JCC in that forum.
I'm happy to come in on that, and obviously the new performance framework is being measured and evaluated as we speak, and there's a report due to come back. We didn't specifically, the context of the JCC yesterday, talk specifically around Powys, but clearly that is something we will pick up and bring to the Finance Planning and Performance Committee in terms of an update regarding the progress we're making around the particular issues in Powys. We've also had the board-to-board discussions as well with members of WAST and the JCC, so we will continue to bring that to the appropriate juncture, Steve. So it's an important point that we drill down on the Powys specific data through our performance reports.
Yeah, thanks, Hayley, and thanks for the question, Steve. Just from my point of view, you know, as board members, as we get out and speak to people, and be they staff or patients, it is an issue that is of considerable concern within our population. And Hayley, I very much welcome the fact that this will come back to the F&P committee for some more focused scrutiny. I think it's a very an important and a very significant matter. So thank you. But anything from you, Steve?
No, thanks for the responses. Thank you.
Yeah, Mick, please.
Thanks, Chair. Nick, I noticed in the paper there was a couple of references to data quality issues, particularly in relation to English provider reporting and, you know, quality and safety metrics. I just wondered to what extent we think that compromises the reliability of our performance assessments, and how much of a risk is that, particularly as we're kind of going into, you know, this is the first time we've seen, you know, quality safety metrics to that extent. And do we have a kind of systematic approach to addressing, you know, the most significant risks in data quality?
Nicola?
Thank you, Mick. Yes, we have transparently reported where there's been data quality issues, and we are investigating the root causes, and if there are any themes of those, through our joint teams, and bringing the report back to the executive committee very shortly. So, you know, obviously we report to board if there's any other underlying issues or things we need to do to change our systems on the basis of that. And yes, we do have a systematic approach to checking our data quality, which is to some extent why these have been picked up.
But are we currently assured that, you know, the integrity of what we're reporting is adequate, or you know, have we got concerns about, you know, the accuracy of the position that we're able to present?
As far as I'm aware at the moment, we can be assured, but as I say, we're doing that further deep dive, and if there are any issues that come up through that, we'll obviously fairly report those through FPC initially and through to the board.
Thank you.
Thank you. So, Kate, did you want to comment on any of that? Please come in if you do.
Thank you. It was just on the ambulance times, and to really comment that it's tricky given our relatively small numbers, but I think increasingly, as much as focusing on absolute times, we need to be looking and tracking the outcomes for our patients, because that is key. It's not always easy, but I think that needs to be something that we give some more thought to.
Yeah, good point. Thank you, Kate. And Simon, please come in.
Thank you, Chair. I just wanted to come in on the mental health, really to just note how far that has improved, and to thank all of those staff and colleagues that have been involved in that improvement. But my question related to the comment in there around the shortfall of local authority capacity and how that continues to impact on our performance around adult care and treatment plans, and whether we know what actions are being taken within the local authority to try and address that particular issue.
Nicola? I can see that Elaine wants to come in, Nick.
Yes, I think
should we ask
if you could draw Elaine in on that one,
yeah,
please, Chair.
please.
Yeah, thank you for the question, Simon. So that relates specifically to our mental health measure part 2, so care and treatment plans. And care and treatment plans are led by a different range of professionals depending on the need of the individual person. We're held accountable for the totality of the care and treatment plan response. However, we are not necessarily the lead for every single patient. So there will be a small cohort of patients where a social worker will normally be the lead in terms of that care and treatment plan. So we have good relationships with the local authority and we are monitoring that. It does have an impact for us. So where their capacity is constrained or where they experience sort of short-term staff absences, that will have an effect then on our performance. So really our relationship with them continues, our close communication around each of those people who don't have a care and treatment plan and making sure we're tracking that through. What we haven't got and what our data doesn't allow us to show really easily at the moment is the percentage of care and treatment plans that are held by each individual professional. But this week I've already asked for that information to be looked at so that we can assess how big an impact this is for us.
That's great. Thank you, Elaine.
Thank you. I can't see that anyone wants to come in. Just a question from me, if I may, Nick, just on colonoscopy performance. And 6.3% against the 95% target seems a very, very big difference there. I just wondered what level of, and I know that there's explanation around clinical capacity issues, but what level of confidence do we have that that will get better, and how quickly?
Thank you, Chair. So it remains a cause of concern for us, and conversations that we have very frequently at FPC, and we're awaiting further information from Public Health Wales and the screening service to be able to answer some of those questions that you're asking in terms of that assurance. It is something that we are tracking very closely through FPC, but at the moment we don't have that trajectory or that level of assurance that I'm able to give you today, I'm afraid.
Okay, I mean, it may be that through F&P, that also may be something that we could just keep sighted on, because it just seems to me to be particularly or exceptionally low performance. But yeah, thank you for that. Okay, well, if there are no other contributions in response to the, sorry, Ronnie, you want to come in? Please do.
Thank you. Chair, I just wanted to assure you that F&P is keeping a very close eye on the colonoscopy procedures. This is not a pleasant procedure for anyone to go through. There's a certain amount of trauma associated with it, and for some patients, rather more trauma than others. And so we are fully sided on that. And I give you my personal assurance that we are determined to monitor the situation closely. Thank you.
Oh, that's good to hear, and thank you for that assurance, Ronnie. Appreciated. In terms of the report, it's here for our assurance. We've been asked to discuss the content of the report. We have done that, and to take assurance that we as a health board have appropriate systems in place to monitor performance and to respond to relevant issues. Again, if anyone wants to dissent from supporting that recommendation, would you please indicate? That is supported. We stick with Nicola, working you hard, Nicola, I'm afraid, but you're going to present to us the annual delivery plan Q2 report. Thank you.
Thank you. So this is our quarterly report for Q2 on the delivery of our annual plan for 25-26 and lays out the progress against delivering the actions in the plan. And as we've discussed further, obviously the plan is designed to deliver our strategy and our wellbeing objectives and to the wellbeing of future generations Act. We have, as explained in the Q1 report when we discussed it, now included the recommendations of the Improving Performance Together letter from the Cabinet Secretary, which includes the Ministerial Advisory Group recommendations and enabling actions and sort of mapping where the plan actions impact on those. I'm going to go to give a very short summary. So in summary, there's good progress against delivery of our plan for 25-26, including those actions that included in Improving Performance Together. Our achievements in the first half of the year are laid out starting on page 13. And the number of actions that are RAG rated by executive colleagues and which has also been scrutinised at Executive Committee and the PPPH Committee. Those at our risk are laid out with the mitigating actions on page 14 and 15. We did note that there are a number of those outside our control, particularly where those require close working with national bodies such as the JCC or DHCW. So the report is here for assurance and happy to take any questions or comments, Chair. Thank you.
Thank you. Colleagues, would you please indicate if you would like to ask a question or make a comment in response to the Q2 annual delivery plan report? Jen, please come in.
Diolch, Cadeirydd. Thank you, Nick. As you said, we gave this a good airing at PPPH not that long ago, and grateful to receive a deep dive on that. I wondered, actually, all of the. I also note the great progress that's been made. I wondered to what extent are all those green, all those actions which are RAG rated as green. Is there any danger that some of those could slip back into amber, or now that they are green, they're going to stay green? What are your thoughts on that? Just conscious to understand how permanent that status is against those actions. Thank you.
Thank you, Jen. So as well as the RAG rating on the colours and whether things are on track, complete, off track, etc. There's also a delivery confidence rating given for all of the actions in the plan. So I haven't gone back to look against all the green ones, and it would take a little while to do that where this there was high delivery confidence, but that could be done, and that would be the way that we would assess that. I think in general our experience usually is that they don't fall back. And obviously we use that delivery confidence methodology to assure ourselves of that.
Thank you. Jen, you okay? Yeah, okay. I'm just pausing to see whether anyone else would like to come in response to this report. Chris, please. And then me.
Thanks, Nicola. I just want to turn to, it's on my page, is page 265, and it's about complex continuing healthcare. And it mentions that it's a critical action, and they were behind because of external expertise being commissioned and assigned at the end of Q2. I just wanted a little bit more of an explanation of what external expertise are we looking for, and when is the timeline for that to be corrected?
Nicola, please respond if you would.
It's probably better for Elaine to respond, but I'm just checking because I'm not using the same board book that you are, I think, Chris.
It's
on
on
the actual paper, it's
261.
page 9, around the action label 6.1. Yes.
Yeah, it's on page 261 on my
Okay.
pack.
I'll let Elaine come in terms of
Okay.
answering the question. No, thank you.
Thank you.
Hi, Chris. I'm assuming this relates to sort of strategic program number 6, continuing in
Yes, it
complex
does.
healthcare.
Yeah,
So in terms of the external expertise that related to Grant Thornton, so they've been undertaking that review work with us around complex care and continuing healthcare. So as we've talked about already today, we're expecting that report from them shortly.
Yeah, no, that's fine. That explains it. Thank you.
Thank you. Hayley, I can see that you want to come. Do you want to come in on that point, Hayley?
No, that's fine. It was just to answer that query that Chris had. It was the same answer as Elaine's.
Okay, thank you. Over to you, Mick.
Thanks, Chair. Nick, I was looking back at a previous report from last year, and it wasn't exactly the same time, but there was around about 12% slippage in the autumn of last year, and we were experiencing 18%. I know, figures mask a whole series of things. It doesn't say anything about the significance of those or about the detail within. But I just wonder, is this a sign of increasing pressure on capacity and resources within the organisation? We've talked about that in a couple of areas today. I know when we met as PECs last time, we were really we had a detailed conversation about the pressures within the organisation and the way that was impacting on meeting deadlines, etc. So just could you give us a sense of whether these are matters of detail or factor, or is this about pressure within the system?
Yeah, thank you, Mick. So I think we have more actions in this year's plan than we did in last year's plan. So I think our reflection as a planning team is that we broke some of those down into more detail. So there is an element of, there's more granularity in this plan, and that might be something we're going to want to reflect on for next year. I think there is a group within that where it is around some of those actions actually being outside our control. So things like the 2 actions around the JCC, a number of things around digital schemes. So we do need to maybe have a think about that in terms of our planning for next year and go back and compare where that was the case in previous years as well. So we do have a group around that. I think other colleagues may want to comment as well. We do keep it under review, particularly when we're looking at these quarterly reports in terms of our future delivery confidence, the capacity that we've got, the pressure on our teams. And we do a lot of due diligence around that delivery competence, thinking about that. We did that in Q1, we do that in Q2. So it is something that we do take really seriously, and we do review quite significantly. I don't think in our discussion that we saw a theme, other than those I've already discussed, necessarily come out on that, but other colleagues may want to also comment.
Can't see anyone offering to comment. Please do come in if you would like to. But Mick, are you assured, or do you want to comment further?
It may perhaps be worth just reflecting on that over the next few months, because we have to measure ambition with reality, don't we? And the organisation is fighting on so many fronts that if we kind of are over ambitious in what we set ourselves, then we're going to keep slipping further and further back. So matter for you clearly, but it was a feature of our conversation in PECS that there was slippage because we were trying to do too much, I think, and we really need to try and avoid that and get the balance right. Stretching, but not tearing, I think is the phrase that's used.
Thanks, Mick. I can see that Elaine and Hayley want to comment as well. So please come in that order, if you would. Elaine first.
Yeah, thank you for the question, Mick. I think it's partially reflective of a really challenging year. And I think, as you've mentioned, there have been multiple priorities for us this year, which have really taken a lot of time and action from a large number of our workforce. When I think about some of the operational plans that we've got a real range in there. So we've got some very detailed ones and we've got some far more broad ones. We've had a number of things that have been delayed because of that external input, and that coming slightly later than we had thought. So that's about a delay rather than not being confident that we will be able to move that forward. And then I'm aware within my areas, I've got a couple of red schemes, and those were red purely because they were very delayed and beyond target at the end of that quarter, but a couple of weeks into Q3, we'd managed to resolve those and move those from red to green. So I think what we're looking at is a real range of reasons here. And I think speaking from my operational directorate, our focus is on making sure that we are understanding really clearly what those barriers are and making sure we're moving those forward where we can or escalating.
Thank you. Over to you, Hayley.
I think it's really helpful reflection, Mick. And so when we set the annual plan, it is at a point in time, and I think it's a couple of words that come to my mind. There's something about, have we built in sufficient contingency to deal with what I would describe as perhaps matters that we hadn't planned for, because and that in the operational context is important, but also in light of that conversation we had earlier about that ongoing discussion about where and how far we need to go, for example, in terms of the financial improvement, etc. So I wonder whether we can loop back over this again in terms of the reflection, certainly as we bring into next year's plan. But I think it is tricky because when you look at the national requirements and the planning framework, we then layer that to what's important to meet population need locally and the priorities we know we need to work on organisationally. I think there is something around to what extent are we willing to, where are we in our risk appetite as a board around ambition, stretch versus realism. And I think maybe we could have that proactive conversation in board development, because I think that the expectation is extremely high from Welsh Government and from the public around what they want us to deliver. But equally, that prioritisation piece is something that perhaps we might want to reflect on going into next year. But some reassurance, we've just talked about the capital programme being slightly behind schedule at this moment in time, but we do deliver the CRL and we do it by year end. There are peaks and troughs in different parts of the organisation, which means we sometimes go ahead of schedule in some areas and behind in others. But clearly what we haven't, and I know we're talking about winter resilience later, what we really don't know sometimes is how hard an operational position we're going to face at certain times of the year. So I think, you've made me reflect around maybe we need to be really clear about where something is really ambitious and stretching versus what the minimum requirements are that we will definitely deliver against. So we'll give that some thought together. Thanks.
Content, Mick?
Yes, thank you. Yeah, thank you.
Thank you. And thank you, Nicola, once again. And so we come to the recommendations against this agenda item, that we consider the report ahead of submission to Welsh Government and that we take assurance that there is a process in place for monitoring progress against our annual delivery plan. Please indicate if you don't support the motion or want to make any comment. So that recommendation is also approved and supported unanimously. We're going to give Nicola a rest, and we're going to turn to our Director of Corporate Governance, Helen Bushell, who will present to us the report on the Strategic Risk and Board Assurance Framework. Thanks, Helen.
Afternoon, Carl. Nice to see everybody again. So I'm delighted to present this report to you. There are three components to it for the purposes of today's meeting. We have the Strategic Risk Register, the Operational Risk Register, and then also the Board Assurance Framework. So I'll just make a couple of opening comments on each of those three sections, if I may, and then very happy to take any questions. I'll also invite executive colleagues who are the senior risk owners for respective risks to comment if appropriate as well. So as you will know as a board, the Strategic Risk Register represents our highest level strategic risks in the organisation. They are those that the board are directly responsible for. They provide an important part of your own board assurance framework and assurances more broadly. There are 12 risks that you approved as a board earlier on in the year. And in summary, for the purposes of today, we have two proposed changes to risk scores that the executive have considered. One is an increase in the transformation score from 12 to 16, and Deb may want to say a little more about that shortly. And that probably reflects the conversation that we had in the Better Together item earlier on today as well, which is very encouraging. Equally, risk 10 on major incident planning, and again, Mez is the senior risk owner. We are proposing a decrease in the score from that, from 16 to 12. Risk scores don't change monthly or weekly because of the level and nature of the risks, but it is good to see some movement when it's appropriate to do so. So that's a high-level summary of the strategic risks. The Organisational Risk Register, Appendix 3 in your papers, or the ORR as we call it, when the board approved the revised risk management framework earlier in the year, this is an additional level of risk that we have integrated into our framework. It's the level that has direct oversight from the Executive Committee, closely supported by our Assistant and Deputy Director group. This is the first time the board have seen this developing level of risk. There are 11 risks currently on the register. It's here for you today to really take some assurance that it is in place, but really importantly for the board to have sight of what's bubbling under the surface, so to speak, underneath the strategic risk level, because that helps inform some of your wider discussions and decisions as a board. We will continue to develop and mature that risk register at organisational level, and we'll continue to provide it in the reports that come to you along with the strategic risk register. And then finally, the board assurance framework, and I'm really pleased to see this continuing to evolve and develop. I hope it will be and continue to be a useful tool for you as a board. It's really the opportunity to sit back and have a look at the overview of what is quite a significant level of detail that rightly sits in the strategic risk register. So the BAF, the Board Assurance Framework, gives you that overview of strategic risk and their scores. Perhaps more importantly, from a board assurance perspective, it allows you to correlate the board's risk appetite that you agreed earlier in the year, the effectiveness and the adequacy of controls and its associated assurance. So on slides 3 and 4 in Appendix B in the PowerPoint pack, that gives you a very visual overview of the quality and level of those controls, and over time allows you to make a better assessment of whether those controls and assurances are working. In summary, there are 9 risks that are operating within the board's agreed appetite. 1 is at target, 2 are out of appetite, and you'll see that there's a question posed in the pack in relation to those 2 that are out of appetite. That's risk 1 on long-term financial balance and risk 7 on the estate. And I'm not suggesting there's a decision on that today, Carl, but I think there is an important consideration perhaps over the next quarter or so about the board's tolerance of those risks being out of risk appetite. and some assessment by executive colleagues as well about whether those controls are adequate, whether the appetite is adequate, or indeed whether or not any of that needs to be reviewed or changed. The next report of the Strategic Risk Register and BAF is due to you in January. And can I just say a big thank you to Steve? He helpfully pointed out to me yesterday there are a couple of minor but important inaccuracies in the report. One relating to a trend graph on risk 3 and one relating to the target score on risk 12. So Steve, thank you for those, and we will make sure that we amend them ready for the next iteration. So very happy to take any questions, Carl. Thank you.
Thanks, Helen. Just before I open up the discussion, Deb, you may want to just offer a comment on the transformation risk. I think, as Helen says, it probably links to the comments. So, please don't. You could reference that rather than repeat it, perhaps. But also, whether Mez wants to come in and just offer a comment on the lower, the decreasing of the score in terms of the critical incidents. If there's nothing to say, Mez, that's absolutely fine. Just wanted to give you opportunity. Let's go to Deb first.
Thank you. And I should have referenced this when presenting the Better Together paper, because actually, if we look at some of the risk scores in here, they were a feature of some of the questions being asked. So I guess I just wanted to make that link. And on balance, because some of those risks have been experienced in phase 1, only felt right and proper really to increase that risk score. So yeah, that's all I wanted to say. Thank you.
Thanks. Anything from you, Mez?
Yeah, diolch. Thank you. Yeah, so in terms of the this risk, we've been sort of discussing over the last few months in terms of what extra actions we could take, and it is about preparedness and response, and also a learning log as well. So in light of the plans that we have in place currently, and also over the last 3 months, we participated in the exercise Pegasus as well, and as part of the LRF, but equally working in Powys jointly with PAVO and the local authority. So we'll continue to review. So we have reduced it in light of the plans and the work with the LRF, but we'll continue to keep it under review.
Thank you. So we have people indicating they want to contribute. We'll go to Steve and then to Simon.
Yeah, thanks, Helen. A really good report as always, and it's great to see this work developing. And obviously, I'll pick up a couple of points. I just wanted to go back to the Board Assurance Framework dashboard that you referenced, and the 2 risks that are currently outside our level of appetite. And I think it's important as a board that we do give some explicit thought to those risks. I think in terms of the finance risk, as I alluded to earlier, we do receive reports regularly in ARAC on the level of financial controls. So that's the mechanism there. But obviously we are due to receive the Grant Thornton work imminently, so they may potentially highlight any further controls that are necessary. So hopefully we can address that issue through those mechanisms. But I'm interested in the issue in terms of the estate risk, and there are already quite substantial controls in terms of our management of the estate. So I think what would be helpful, and I'm not seeking an answer today, but it's something that I think would need to be considered over the next few months, is what further action we could take as a board to to further mitigate risks to bring that estate risk back into appetite. Thank you.
Do you want to respond to that before we go to Simon, Helen?
Yeah, thanks, Steve. Really helpful. So I agree with you entirely on the financial risk, and I think the things that you outlined are absolutely right. I think the work that Hayley outlined earlier on in the meeting around the route map to financial balance will be another significant action and therefore become a control. And I think that may well make some difference a little bit later in the year on that as well. The estates one, Pete may want to comment, but I agree with you. I think that is an area that we need to look at. We closely associate the estate with quality, rightly, and we have a very low tolerance around risk appetite for quality. Now, it may be that it's not quite as black and white as that, and we perhaps need to be a little bit more sophisticated. So I think there's something about, excuse me, the appetite approach, but absolutely the controls. And I think we'll undertake to go and have a look at that. Thank you.
Thank you. So Helen, where and how would we do that? Is that an ARAC, something that would come to ARAC, or would you suggest somewhere else?
So estate sits within the remit of Finance and Performance Committee. So we'll do that there as part of the committee risk register, but we'll report it directly back to board as well.
Okay, thank you. Coming to you, Simon.
Thank you, Chair. It was really a question around where we should expect to see perhaps reference as a control at the strategic commissioning framework and its implementation, whether that's something which we should be seeing in the kind of finance risk, or whether it should be sitting in the risk in relation to commissioned services. But I didn't really see it referenced, and it seems to be quite an important part of our recent decision making that you'd expect to see featuring as a control somewhere in the risk landscape.
Yeah, thanks, Simon. I think that's a great point. I'll need to go away and look at that with Pete and Nick specifically. And it may be that it's a control in multiple areas. It doesn't necessarily have to be in one. So I think that's a really fair challenge, and we'll take that as an action, Carl, to go and have a look.
Thank you, Simon. So that seems to be all the questions or contributions in response to the strategic risk and board assurance framework. So we received this for assurance. We are asked to review the November 25 strategic risk register update, included at Appendix A, ensuring that it is a complete and a true reflection of the Health Board's current high-level risks. Also, to review the November 25 BAF dashboard, and we've seen that in Appendix B, and we need to ensure ourselves that it too is a complete and true assessment of the Health Board's confidence in its strategic controls and assurance. And we've highlighted one or two points about that. Also, the recommendation is that we take assurance on the development of an organisational risk register, the ORR, encompassing the most significant operational risks of the organisation. A high-level summary is in our papers at Appendix C. Also, that we take assurance on the controls and assurances to manage strategic risks, and there are actions to address any identified gaps. And the final component of this recommendation is that we approve the updates proposed by executive leads, including the increase in scoring for the transformation risk score, SRR 002, and the decrease in scoring for the major critical incident risk, SRR 010. Colleagues, any comment, or does anyone want to indicate that they don't support that composite recommendation? That therefore also is supported and agreed unanimously. Not much of a rest, Nicola, because we're coming back to you again, and to the item 3.8, our plan for winter and our winter resilience arrangements. Thank you.
Thank you. So I present this paper on behalf of the Health Board, but it is very much a team effort with Elaine's team and Mez and others. And obviously it is very much a partnership plan and winter resilience, system resilience plan that is developed as well as in partnership through the Health Board, very much in partnership through our PB with our R3PB partners and through the arrangements. So very succinctly, we have met the Welsh Government requirements through the various correspondences and guidance that we've had since before the summer on guiding our system resilience planning for the winter. As I say, the plan that's put before the board today was developed in collaboration through all the methods that I've just described, and as a result was submitted to Welsh Government on the 31st of October as our partnership plan. So it's therefore here for information for the board, and will then go to the RPB board in December formally for noting, but it has been signed off through the RPB executive, and we had confirmation from partners that they were content with it before it was submitted to Welsh Government. So thank you, Chair, and between us, happy to take any questions or comments.
Thank you, Nicola. Colleagues, would anyone like to respond to our winter resilience plan? Jen, please.
Thank you, and thank you, Nick. And as you say, it's been really good to see that this report is sort of under the auspices of the RPB, and there's been a lot of collaboration and joint partnership working. So that's good to see. It would be super if you could share maybe an example, or what one of your executive colleagues will share an example of how a good example of how that collaborative work and partnership working is really helping us make sure that our resilience plan is where it needs to be. So yeah, it would be great if somebody could bring to life for us what that partnership working looks like. And secondly, I note, Nick, that in the report, that reporting back to Welsh Government eventually when it needs to go back to Welsh Government, that I think what you say in the report is that there are sort of various mechanisms for that. It's from that I'm picking up that each partner will be sort of reporting back to Welsh Government sort of rather separately or independently. I don't know whether if I've picked that up correctly, but I'm just a little bit intrigued by that, given that the whole plan is a plan which is all of us working together, which is fantastic. But Welsh Government are actually wanting to receive sort of updates from constituent partners. I don't know whether I've understood that correctly, but so I'd be grateful if you could highlight, if you could, help me understand that a bit better. Thank you.
Nicola.
I'll leave it to Elaine and Mez to bring forward an example. Probably Elaine's best place to do that. But in terms of the monitoring, yes, we will be monitored through our IQPDs and future jets on the delivery of the winter plan. Obviously, the accountability arrangements for the various organisations are different. However, there is a new group being established in the RPB that has for all RPBs, that has a more direct sort of accountability of the partnership arrangement. I'm not quite sure when that is starting. Maybe other colleagues can help me out. But we have nominated a lead exec to sit on that group as well. Obviously, that group hasn't quite formed and started yet, but I would have thought winter planning would feature in that arrangement as well, Jen. I think Welsh Government may have identified there's a gap there in terms of bringing all partners together in that accountability way.
Thank you. And you mentioned JET, Joint Executive Team.
Joint Executive Team.
Just to be clear about the acronyms, yeah.
So I beg your pardon, yes.
Thank you.
IQPD is our Integrated Quality, Performance and Delivery meetings with the Welsh Government, which are monthly. And JET's Joint Executive Team meetings with the Welsh Government, which are part of the performance arrangements, which are biannual.
Thank you.
Thanks, Nick. Just before I invite Elaine and Mez to come in, just in response. So I've recently, since our former Vice Chair colleague, Kirsty, took up her new role in Cardiff as Chair of Cardiff and Vale Health Board, I've at least temporarily stepped in as Chair of the RPB. There is a lot in the academic literature about so-called messy governance when it comes to strategic partnerships, and what that literature teaches us generally is that there are both advantages and risks when it comes to messy governance, and I think we experience some of that through RPB. So you're absolutely right, Jen. The RPB is a partnership, it's there by statute, but it's not a delivery agency. It isn't set up as a legal entity per se, and therefore accountability for delivery lies with the sovereign bodies, the constituent parts of the RPB, working in that statutorily mandated partnership. And just in response to Nicola, those new arrangements have been stepped up. There are meetings in the diary around, forgive me, I can't remember the exact terminology, but it's around integrated care accountability meetings and so on, and they will be happening imminently, actually. And so so it is, as I say, it is that environment. But we as a health board essentially are accountable for the elements of the winter plan that we deliver. And clearly as a board, we will need to keep sighted on the fact that we are doing our bit effectively. So I don't know whether any of that helps, but Elaine Mez, please come in.
Yeah, thank you for your question, Jen, about examples. I could probably refer to 3 instantly. That's probably too many than your question asked for. I think it's really important before I mention that to say that this year there hasn't been for health boards any additional winter funding, and there has been the expectation that health boards will work on the plans and the delivery mechanisms that we have throughout the year to ensure that we have the appropriate flow and response for our population. So what we have in place within Powys, the 3 examples that I was going to touch on, one which is around being proactive, proactively preventative is the aim for our most at risk population. And we have a supplementary service with every single GP practice that our community teams and our local authority and third sector teams wrap together around. We can call it virtual ward, we can call it our community resource team, but the ambition is that we identify those people who are most at risk at deteriorating rapidly and requiring or potentially requiring an admission, and we proactively wrap around those individuals to enable them to stay in the community. Now this year, as they did last year, Welsh Government have issued an additional directed supplementary service to general practice to pick up these activities. We do not need to use that because we already have our own local supplementary service, which is all year round, and we are the only health board to have that. So that gives an opportunity for collective working to proactively prevent people going in. We have also, since April this year, pulled together our Flow Hub to help manage the flow of patients through our hospital settings. We manage that and we coordinate collectively with our local authority partners every single day. We review people who've been in hospital for a lengthy period of time every single week. And that gives us a mechanism to understand that flow. And we had already talked about some of our pathway of care delays. And equally, since April, we've changed the way that we operate our enablement and reablement services in the community in order to bring people home, or if possible, prevent people being admitted who need more rapid, active in-house response or recovery following admission. And both the local authority and the health board have elements of that service, work together to communicate together around that, but those are separate services. So those are 3 examples, but those are things that we have been running all year. And as Carl has mentioned, the Regional Partnership Board and Regional Partnership Board Executive, as well as the meetings that we have with the local authority through our joint leadership team, is where we also get to ask questions, because the local authority have received additional funding this year to support the pressures that we are experiencing in hospital. So we've already mentioned that we have started to see a reduction in some of the assessment delays there.
Thank you. Mez.
Yeah, thank you. And similar from Elaine's theme really around prevention there. So around care homes, you will see obviously vaccination a key priority in terms of the winter plan. There's been joint work
with colleagues in the local authority who link into care homes on a daily basis to promote vaccination. I'm pleased to say that, for COVID, it has achieved over 75%, which is the highest in Wales for care home residents. So that is, good news. But wider than that as well, we have a team that works across the local authority and health around health protection, that around infection control element really, and also if a resident becomes ill with a winter infection in terms of either flu or COVID or respiratory infection, then we have champions that have supported health boards to look at how we can improve prevention and IPC in care homes, which also helps in terms of any outbreaks, closing them down very quickly, obviously to protect first and most residents, but also that also helps in terms of flow of patients across the system as well, from hospital to care home. So that helps.
Thank you. So just on the back of the comment just then, in terms of the Pathways of Care Transformation grant that has been allocated to local authorities from Welsh Government, that's in the report. I just wondered whether there was any. So it's good to hear from Elaine that that's already having a positive impact. I just wondered whether there was any statistical or quantifiable targets behind the measures. The measures in the report are trend measures, really. So a reduction in people waiting for assessment by social care, for example. But a reduction could be 1 or it could be 100. So I just wondered how we will know the extent of the impact that this funding has had. Perhaps we could just hold that as a question, please, and I'll invite others to come in. So Ronnie and Chris, and then Mick, and then we probably need to move on to our next agenda item.
Thank you, Chair. For me, this plan is quite detailed, and I've read it with care and consideration. I suppose from my perspective, what I'm just reflecting on is how the winds of circumstance might blow some of this off course. And we've talked about aspects of that earlier on in this meeting. For instance, and this is just a specific example, Elaine, if I look at in-hospital staffing capacity, the rosters are signed off 12 weeks in advance, escalation procedures well established, and local resilience regularly tested. Just how often is the resilience tested? And are we satisfied that actually there is sufficient strength within the system that if the winds of circumstance come along and they are rather more severe than expected, that we can withstand the pressure? I think all that I'm saying is, do we have anything in this planning mechanism which is a hostage to fortune? Thank you.
So I'll invite Chris as our final contributor, and then I know that Elaine, and then back to Nicola. So Chris, please.
Yeah, thank you, Carl. The transformation grant was one that I was going to pick up on because I thought it was the one with the local authority, but again, it would be having more detail. I think when Jenny mentioned about some of the examples, that would be a good one to be able to unpack a little bit more. Does that include English hospitals or as well as the Welsh hospitals for that pathway, because we commission outside? Mez mentioned about the vaccination rates in care homes, and I was going to pick up on that because I had noted the 75%, which is significantly on the. Is that an improvement to what we achieved last year in relation to that? Because that would show progress there. And then in relation to WAST, it's got about winter preparedness. How is that different? Do they put on different number of vehicles or more crews, or a different type of vehicle? And what influence do we have there?
Okay. Elaine, please come in, and then we'll go back to Nick for a final response.
Certainly. So I think there's three things that I'd pick up on. So Ronnie, your point, are we at risk of being blown off course? And I think there's always unexpected things happen, or there's always changes that happen in terms of the demand for our services. So reflecting on our pathway of care delays, we saw an increase in those in September, because we also saw about a third increase in activity coming through Wye Valley. So there are changes in demand that happen, some of which we can expect, some of which we can't expect. So what you've got in the report today is very much our forward look and our forward plan, but we also have responsive and reactive day-to-day mechanisms which enable us to understand what's happening right now, what is changing, and how do we respond to that. And our Flow Hub, for example, is one of the mechanisms that we have to help us respond to those changes that we may not be able to have fully expected. Carl, you raised a point about metrics from the local authority. At this point in time, we don't have any such metrics that you describe. However, we have had a conversation about the joint dashboard that we have with the local authority and strengthening that so that we can see certain changes happening on a regular basis, and that is shared information that we have, so that we can understand if it is 1 or if it is 100-person change, and we can use that then to inform our discussions. But in terms of what Welsh Government are monitoring, I'm not aware of any such metrics that they have asked from local authorities. And then, Chris, you raised a question about hospitals in England. My understanding is that the local authority and the use of that transformation grant is to the benefit of all Powys residents. So if those Powys residents happen to be in an English hospital, for example, or a Welsh hospital, they would be able to utilise that money to deliver services irrespective of where they are. And we have had a considerable number of conversations, an agreement with our local authority colleagues about how we manage some of those assessments in England, how we repatriate patients into our hospitals or our services as effectively as possible, so that we can make best use of that transformation fund. And although we don't receive it, how do we interact then with those teams and that work that the local authority is doing to deliver against the plan that they put together for that use of that transformation fund?
Thank you. Nicola, Hayley would like to offer a comment or observation as well. Perhaps we'll give her the final word, but is there anything else from you or anything you want to say? No? Okay. Hayley, please.
Yeah, it was just the conversation that we've had regarding the 30 million investment placed into social care to support with winter pressures. I was in leadership board yesterday where we discussed that and how that fitted in terms of measuring impact. So although we haven't had that locally, I know nationally they're looking at that currently in the context of particularly the winter sprint fortnight, as they call it, from the 8th to the 22nd of December, where there's a reset fortnight to try and get us ready before Christmas in terms of flow and demand, and a particular effort around ambulance handover, the Handover 45 project, and all system partners working during that period to try and manage demand and flow so that we're in a better position as we go into the Christmas week. So I just wanted to mention that discussion is taking place nationally around how some of that impact around the direct social care investment that went directly to authorities rather than through regional partnership board arrangements would have an impact on winter. Thanks.
Thank you, Hayley. So, colleagues, again, we come to our recommendation for assurance, that we take assurance that there's been an extensive process of development for the plan, led by the RPB, with active participation and coordination of Health Board, Council and third sector input. We also take assurance that the plan has been submitted to Welsh Government to meet the deadline of the 31st of October, and we note that the final version of the plan is being provided to the board today for information and will be submitted to the RPB for noting at its meeting on the 16th of December. Are there any comments or people wishing to not support that recommendation? That too is supported. So we're back with Helen and the report from our Director of Corporate Governance. Thank you, Helen.
Thank you very much, Carl. So a relatively brief report from me for this particular board meeting, just 3 things to draw out, and then perhaps Carl, I'll come back to the secondary paper on the model standing orders. So in my report itself, we outline the board activity that has been taken place since the last meeting on the 24th of September. That includes, for the public's benefit, the agenda that was considered in the last in-committee meeting in September as well. 3 chairs actions have taken place in relation to general dental services, extension of the National Silver Cloud contract and a Better Together decision, and the common seal has been applied on 1 occasion in relation to the electric substation at Brecon Hospital. So that's all I was really going to pull out, Carl, in terms of the report itself. Perhaps with your agreement, I'll come back to the model standing orders.
Thank you. Does anybody want to ask a question or respond in any way to Helen's report? No. So the report is here for approval and we are asked to receive it, to ratify the 3 chairs actions as outlined in the report, to ratify the application of the common seal, which was applied on 1 occasion on the 26th of March, and that we receive assurance that that action was taken in accordance with section 9 of the standing orders. Unless anyone indicates to the contrary, I'll assume that everyone supports the recommendation. That therefore is supported. So model standing orders. Thank you, Helen.
Easier said than not. Thank you. Yeah. So the model standing orders are essentially the bedrock or the foundation of our governance as a health board across NHS Wales. The standing financial instructions are one component part of that, and it is particularly those that I draw your attention to. We have made a number of changes based upon national guidance to these throughout the year. This change, though, is a recommended local change, and it's in relation to reviewing and recommending to you a change in our executive authorisation levels. Authorisation levels currently are very low. That's a historic issue that was made for good reason some years ago. We've reviewed these and compared and contrasted across a number of other NHS Wales organisations, and we've thoroughly debated these and considered them at our Audit and Risk Assurance Committee back in October as well. So the recommendations being made to you is that there's an increase in the Chief Executive delegation to 500,000, the Director of Finance delegation to 250,000, and the Executive Director delegation to 100,000. There are no recommended changes to Assistant Directors and other groupings of staff that have delegated budget access. We've also taken the opportunity just to tidy up a number of what I would call administrative points, job titles, points of clarification. All of those are available to you in the document as track changes, just for absolute clarity. So happy to take any comments. Carl, thank you.
Thank you, Helen. Could I just clarify one thing? So when it comes to sign off above those thresholds, the higher threshold requires a chair sign off as well as a CEO sign off, and whether that needs to be reflected in the changes.
So above 500,000 would require chair and chief. Some things would require whole board sign off, Carl. It depends what they are.
Yeah. I'm just thinking. I'm not sure that the chair's responsibility is reflected in the wording. Forgive me if I've missed it.
Very happy to go back and make sure that that's the case, but and we'll make sure that that's the case. But the intention there, Carl, just for clarity, so anything up to and including 500,000 would sit with the chief executive or other relevant executive colleague. Anything above 500,000 would be the responsibility of yourself as chair and the chief, or the whole board, depending.
Okay. Okay.
And I'll make sure, with your agreement, I'll make sure that that's clear.
Okay. Thank you. So, colleagues, any other comments? Any questions? No. So we are asked then to approve the proposed changes, that executive authorization levels are increased to 500k for the chief executive, 250 for the director of finance, and 100 for the executive team. That a series of administrative updates are applied to the SFIs, including executive and other job titles, board committee names, external agency names where appropriate. And we note that the chief executive will complete a review of the executive portfolio scheme of delegation in readiness for our January meeting of the board. Again, I'll assume support for the recommendation, but I will pause should anyone want to indicate to the contrary. Thank you. That too is supported. And so we keep with Helen, and we consider changes to the IPFR, the individual funding requests for the JCC. Thank you, Helen.
Thank you, Carl. Kate is technically the executive director for this particular policy, but I'm presenting it as a governance matter today, but I'm sure Kate may want to comment a little bit later on as well. So the IPFR, the individual patient funding request policy, has both a national and a local remit to it. And as I said, Kate is the executive director responsible. The board has previously approved this policy. There were a number of areas of debate and clarity, I think, that have taken place over the last 12 months or so, and we've now arrived at a position nationally with the JCC, but also the other 6 kind of partner health boards across NHS Wales, where we've now arrived at a renewed national policy. You'll note in the paper that there was a clarification point needed on the approval of the JCC. Because they only met yesterday, I'm happy to confirm that the JCC itself, with Hayley's attendance, did approve this national policy on an all Wales level. It still requires the approval of our board, as all JCC policies do, and the other 6 health boards will also be considering this during the course of their board meetings in the coming weeks as well. So it's an all Wales policy. Carl is here for consideration and approval for it. Thank you.
Simon, please come in.
Thank you, Chair. Just to seek some clarification and assurance around kind of quality assurance around the implementation of this national policy. So how do we as Powys Health Board operate it? How do we get quality assurance around that? What and how is learning shared? And also, what kind of reporting mechanism would it be appropriate for us to adopt? And my suggestion would be some kind of reporting into the Patient Experience Quality and Safety Committee, probably incorporating into some existing report might be helpful, so we have line of sight to the number of these cases that are being considered within Powys. So I hope that's helpful.
Thanks,
Kate,
Simon. Carl, I think Kate's going to respond to that.
Yeah, thank you, Simon. So important question. Excuse me. So there is significant collaboration between our local team and the national team, and we receive quarterly quality assurance papers from the national team on the process, both nationally and with some local comments. So a selection of our cases are QA'd, essentially, and that is fed back. So our local panel will consider that and consider the learning. If there's anything significant, that will be escalated to me. That hasn't happened so far, but any queries are. So I think the mechanisms are there and are in place, and the learning does happen. In terms of local reporting, I think bringing it to PECS is a good idea. I'm not sure we're currently doing that, to be honest. So we can have a think about how we might best do that.
Thank you.
Great, thank you.
Hayley, was there anything that you wanted to add to that?
I think it's a really important point that Simon raises, and Kate's just described the local arrangements, but I do think there's a point of reflection. So the JCC has a subcommittee which focuses and receives report on a national basis on this work. And there are several committees from finance, planning and performance, patient experience, quality and safety. So I think there's a broader question, Simon, that in the context of the IPFR, but in the context of the linking of the reporting from those mechanisms through to our committees, that perhaps we could pick up to address. It's specific around, I think with the IPFR, we get quite a lot of the detail as Kate described, but I think there is a little bit of working out the strength of reporting to our various committees from the JCC arrangements. And I will pick that up with Helen going forward, because I think it's a really important matter. And I think it's about what's our Powys population's experience of that is a very different conversation to looking at it with a national lens. So we'll pick that up. Thanks, Simon.
Okay, thank you, Hayley.
Thank you, everyone. There are no other contributions. Any additional final comment from you, Helen?
Not from me, Carl, thank you.
Okay, in which case we are asked to approve this, and the recommendation is that we approve the local adoption of the All Wales IPFR, the Individual Patient Funding Request Policy, subject to consideration by the Joint Committee, the Joint Commissioning Committee on the 26th of November this year. Again, if anyone wants to indicate that they don't support the recommendation, please do. That too is supported unanimously. So that brings us to the final item on our agenda, which is item 3.11, the minutes of the previous meeting. Are there any matters of accuracy or any suggested amendments or changes that anyone would like to suggest? And if not, then I'll assume that we approve those minutes as a correct record of our last meeting. Thank you. We have the consent items under section 4 of our agenda, and as I explained earlier, we don't open those up for discussion now, but we approve them en bloc. And that takes us to item 5.1 on our agenda. I'm not aware of any other business, so there is nothing to consider there, which means that the business for this meeting is concluded, and we look forward to our next meeting, which is scheduled for the 28th of January in 2026, remarkably. But colleagues, we are now scheduled to move into an in-committee and in-private session. And in order to do that, we need to agree the usual motion, which is under section 1(2) of the Public Bodies Admission to Meetings Act 1960. And that motion reads that that representatives of the press and other members of the public shall be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. I do confirm that the advice to me from the Director of Corporate Governance is that this is needed in terms of the content of our in-committee agenda. So I assume that, again, there will be support for that motion, but please indicate if you don't. Thank you. So it just remains for me to say a big thank you to everyone for preparing for today. It's a huge amount of work that goes into those preparations and the content of the papers and the reports and so on. Much appreciated as always. And thank you to those who have attended our meeting online and to those who will watch our meeting recording following today. So really good to see you. That concludes our meeting for today. Thank you.